Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with the director of the Yale Cancer Center, Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about lymphoma with Dr. Francien Foss. Dr. Foss is a professor of medicine in hematology and of dermatology and is director of the multidisciplinary T-cell lymphoma program at the Yale School of Medicine. Here's Dr. Weiner.
Can you just tell us a little bit about what made you interested in treating patients with cancer and specifically in lymphoma? What turned you on to this when you were in medical school or in internal medicine training?
So that's a very interesting story, and it actually goes back to my childhood, believe it or not.
Okay.
When I grew up in high school, my best friend Elizabeth's father had a very rare skin condition with all these red blotches all over his skin. And he had to actually travel to a special center at Dartmouth to get radiation for this, what they called this cutaneous lymphoma. So at the time, I was aware of it, but I didn't fully understand what that was until later on when I got into oncology. And I found that actually was mycosis fungoides cutaneous T-cell lymphoma. So I guess my interest was piqued way back then. But when I was in college, I was interested in science and biology, and I was fascinated by hematology and looking under the microscope and blood cells, and tried to do research in that area in college, and then subsequently decided to go into a medical oncology fellowship.
For our listeners, can you just talk for a minute or two about lymphoma and what lymphoma is, what tissue it's arising from?
Lymphoma is basically a disorder of white blood cells. Now, there's lots of different types of white blood cells. Lymphoma specifically arises from lymphocytes. There's a whole diverse, different number of lymphocytes that can give rise to lymphomas, including T cells and B cells, and even other types such as NK cells that somewhat fall into our category as well. So these are basically tumors of white blood cells. Most of the time, these white blood cells live in lymph nodes. However, they're capable of trafficking through the body in the blood and also getting into other tissues in our body as well.
And just to make this even a little more simple, tell us for a minute about the difference between a B cell and a T cell. So they're both lymphocytes, and what do B cells do and what do fundamentally T cells do? I know people have heard a lot about T cells vis-a-vis HIV infection, but I think most people are less familiar with T cells.
So basically, when your bone marrow cells decide to make a lymphocyte, they can either make a T cell or a B cell. The B cells produce antibodies, which protect us from infections, and the B cells mostly live in lymph nodes in our body. T cells also can help us to fight against infection, but T cells are a little bit different. T cells like to circulate into other tissues in our body. So, for instance, the skin, the liver and the spleen, the intestines, even in the brain, there are T cells. So T cells may be the first line of defense to recognize foreign things such as infections or viruses. And then T cells stimulate an immune response. They recruit B cells to come in and produce antibody once they recognize an infection. So the important thing about T cells is that if T cells are depleted in your body, such as by the HIV virus, your body loses the capacity to recognize and get rid of those very bad infections and those very bad viral conditions. And that's why people with AIDS are susceptible to some of these very unusual types of infections.
And we'll get to talking about T-cell lymphoma in just a minute. But how many different kinds of lymphomas are there? Because as myself, a medical oncologist, I have to say that I find the lymphomas very confusing.
Well, the lymphomas are confusing even for those of us that specialize in lymphoma. And if you ask me how many, I would say, are you talking about today, 6 months ago, or a year from now? Because Basically, there's a thing called the WHO, the World Health Organization, that classifies diseases such as lymphoma. And every year they meet, and every year they seem to add a different group, a new group of lymphomas. So basically what they're doing is they're using very sophisticated modern molecular techniques, such as sequencing and other things. They're able to take a common lymphoma, such as diffuse large B-cell lymphoma, and divide it into now at least 4 or 5 different subcategories. So I think it's a moving target, Eric, and as our diagnostic capabilities get better and our understanding of biology gets better, we're going to see that these entities are going to be described, these new entities.
And how many individuals have lymphoma each year, for example, in the U.S.?
So there's about 75 to 85,000 people who have B-cell lymphoma. There's about 9,000 who have Hodgkin's and about 8,500 who have T-cell lymphomas.
That's still pushing 100,000 people. That's pretty common.
It's a significant problem, and one of the issues is that as we age, our immune system is less and less able to fight off mutations that occur in our cells at all times. So the incidence of lymphoma actually rises in older people. And as we're all living to be older and older now, we're starting to see many patients in their 80s and even in their 90s.
And my understanding is that these lymphomas, while typically very treatable, range from those that grow very, very slowly, sometimes are curable, sometimes aren't, to much more aggressive processes that can also sometimes be cured, but can also threaten someone's life in a fairly short period of time.
One of the interesting things about lymphoma that you just brought up is the paradox, which is that lymphomas that we call indolent lymphomas, which is low grade, not going to affect your life perhaps, actually are incurable lymphomas, whereas those that we call aggressive, such as diffuse large B-cell lymphoma and T-cell lymphomas, actually will kill you if we don't treat them. So the word indolent is used, but it doesn't necessarily mean that there isn't a lymphoma. It doesn't necessarily mean that patient may not need to be treated.
Sure. And I know there's no one presentation of individuals who have lymphomas, and that there can be all sorts of different symptoms that people have that bring them to medical attention. But can you just talk about a few of the more classic presentations of lymphoma?
So the classic thing we think about and what we teach medical students is that lymphomas can present with what we call B symptoms. That's fevers, night sweats, weight loss, those kinds of symptoms. In fact, only a small proportion of lymphomas actually present that way. Many of our lymphomas present because somebody notices a lump. They feel a lymph node, or their physician is examining them and feels a lymph node. Perhaps there's another symptom that leads to a patient getting a scan, and then that scan shows us a problem. Some patients can present, say, if the lymph node or the lymphoma is compressing, say, like their lungs, for instance. They may have trouble breathing, or it's compressing their intestines. There may be issues there. So I think there's a wide variety of ways that these diseases can present.
And lymph nodes are present really throughout our bodies.
Everywhere in your body. In fact, if you feel around your elbow, you may or may not realize that there are lymph nodes there as well.
And do those lymph nodes ever become lymphoma?
Though any lymph node in your body can become lymphoma. And the other thing is lymphomas like to travel to other lymph nodes. And so just because the lymph node doesn't look like it's enlarged doesn't mean that perhaps the lymphoma hasn't spread there.
Sure. The treatment of lymphoma has just changed dramatically over the past couple of decades. When you and I were earlier in our careers, my recollection is that the primary treatment for lymphoma was chemotherapy. And can you talk a little bit about how effective chemotherapy is and maybe what some of the newer treatments are based on?
So the effective chemotherapy really depends on the type of lymphoma that you're looking at. But generally speaking, if you take diffuse large B-cell lymphoma, which is the most common aggressive B-cell lymphoma. With conventional chemotherapy, with, say, the regimen we call CHOP, that was actually developed a long time ago at the National Cancer Institute by Dr. DeVito, one of our former cancer center directors. That particular lymphoma is cured in about 50% of patients. So there's good news and bad news. If you're in that 50%, that's great. But the other way to look at it is that 50% of patients go on to have relapse or not respond, and they need additional therapies. And the fact of the matter is when we were just in the world of chemotherapy drugs, we really didn't have great effective ways of treating those patients once they relapsed. And as you said, that's all changed now in the modern era with immunotherapy.
And the first of those immunotherapy-like treatments was the drug Rituxan, am I right?
Correct.
It's still widely used.
It's a mainstay for many of our patients with B-cell lymphoma.
Yeah, it's very widely used. And I think perhaps like the drug that I'm very familiar with in breast cancer, which is called Herceptin and is for a specific type of breast cancer, I think it's a drug that when it was first developed, no one realized quite how good it would be. And it's turned out to be a very remarkable drug.
I think the most remarkable thing was very early on when somebody got the idea of combining it with chemotherapy. So instead of just giving the CHOP chemotherapy, we added the antibody Rituxan, and that made a huge difference. I think it was a major shift in terms of our understanding of these lymphomas and our ability to treat people and cure people. So I think that was a major, major step forward.
And CHOP became R-CHOP.
Exactly. And now everything is R. So any combination chemotherapy you give, you're generally going to use the R with it.
Yeah. And but Rituxan was just the beginning, and there's so much more.
Rituxan has led to the concept that monoclonal antibodies can be synthesized. More importantly, that they can be humanized so that the body doesn't reject them, and that there are multiple other epitopes or proteins on the surface of cells that can be targeted. So Rituxan targets CD20, but there are also antibodies targeting CD19 and many, many other receptors as well. But the tip of the iceberg was the antibody itself. What's happened subsequent to that is that we figured out how we could hook that antibody up to different things and use it as a way of delivering other therapies. And that's really how immunotherapy got started.
So Rituxan is essentially added or connected to something else.
Correct. The Rituxan antibody is used only as a way of targeting another therapy that can then be delivered to the cell.
And does the Rituxan, as part of that combination, continue to exert an anti-lymphoma effect?
Potentially. I think people think there are multiple ways that those targeted agents work, one of which, of course, is just simply blocking that receptor or affecting the way that receptor is signaling in the cell.
Well, we're going to need to take just a brief break. When we come back, we're going to talk about cutaneous T-cell lymphoma. We're also going to talk a little about treatments like bone marrow transplantation and cellular therapies for individuals who have lymphoma. So hold on. We'll be right with you again.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where their Center for Gastrointestinal Cancers is committed to detecting pancreatic cancer early and using state-of-the-art technology to treat the condition. Learn more at smilowcancerhospital.org. There are over 16.9 million cancer survivors in the U.S. and over 240,000 here in Connecticut. Completing treatment for cancer is a very exciting milestone, but cancer and its treatment can be a life-changing experience. The return to normal activities and relationships may be difficult, and cancer survivors may face other long-term side effects of cancer, including heart problems, osteoporosis, fertility issues, and an increased risk of second cancers. Resources for cancer survivors are available at federally designated comprehensive cancer centers, such as the Yale Cancer Center and its Milo Cancer Hospital, to keep cancer survivors well and focused on healthy living. The Milo Cancer Hospital Survivorship Clinic focuses on providing guidance and direction to empower survivors to take steps to maximize their health, quality of life, and longevity. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Hello again. This is Dr. Eric Weiner, and I'm here with Yale Cancer Answers. I'm joined by my guest, Dr. Francien Foss, a clinical expert and a researcher focused on lymphoma and specifically cutaneous T-cell lymphoma. So before we get into talking about cutaneous lymphomas, maybe we can just spend a few minutes talking about some of the treatments that you often consider when patients have not done as well with their initial therapy. So treatments like transplantation and various types of cellular therapies.
Great question. I talked at the beginning about the fact that if you look overall at all types of lymphoma, unfortunately, about 50% of our patients need a subsequent therapy or come back to us with relapsed disease. We're fortunate now because we actually have a number of different ways to treat those patients. Starting off with some of the novel biologic agents, which we mentioned could be monoclonal antibodies hooked up to toxins that then get directly delivered to the cell. Also, another use of these monoclonal antibodies has been to design what we call cellular therapies. I want to just mention the word CAR T because I think many people have read about this in the New York Times and know that this is an emerging therapy. So basically what CAR T is, it's a way that we take a patient's T cells and we then engineer them genetically by injecting a gene into those cells that targets them, say, to CD20 or another protein on the surface of the cancer cell, and also activates the T cells. So basically, the T cells get taken out in the blood bank like you're donating blood. They get sent off to a company where all of this genetic engineering takes place. They then get sent back to us. The patient, in the meantime, comes in and gets some chemotherapy to prepare them to get the cells, and then the cells are infused like a blood transfusion. It turns out that this has been highly effective in that those T cells are now activated and specifically target the tumor cells. So they go to the tumor cells and they act like little killers to kill them. We've been able to actually cure patients with B-cell lymphoma that have failed all chemotherapy agents with this approach. It's very exciting, and it's now being used for many types of lymphoma, also other solid tumors, and perhaps other indications as well. So I think at this point we are in the era of immunotherapy and also in the era of cellular therapy for patients who've relapsed.
And this is really the ultimate targeted therapy, is it not?
It is. The nice thing about this therapy is that we're using your own body's defenses. We're using your own T cells. We're basically activating them to make them better soldiers so that they can go in and do the job that they're programmed to do, which is to kill off tumor cells.
Even though it's very targeted, there are still some number of side effects, correct?
Correct. And that's been a learning curve for us in the clinic. The side effect of this is that when you activate T cells like to secrete all kinds of factors that will kill tumor cells. Some of these factors can cause low blood pressure and fever and other complications. We call that cytokine release. So that's one side effect that we see. And the other side effect is very interesting, and we didn't really expect this. And that is because T cells can get in and out of your brain all day. That's part of what they do. Some of these T cells can actually get into your brain, and if they're activated, they can cause some neurologic symptoms, such as difficulty with handwriting and short-term memory loss. All of these things are short-term, and from almost all of our patients, these are reversible, but they're things that we've learned how to manage.
And is this now a therapy that would be used in place of bone marrow transplantation?
So prior to the CAR Ts coming into the clinic, what we would typically do if you had a relapsed lymphoma after chemotherapy is we would give you more chemotherapy to try to get that lymphoma in remission, and then we would do a bone marrow transplant. So that bone marrow transplant could be using your own cells, which we do in the case where you actually have a complete remission and we can't find any residual cells in your body. Or in other cases, it would be getting stem cells from somebody else, an allogeneic transplant. So both of those transplants require getting stem cells and then reinfusing those stem cells after chemotherapy and then being in the hospital for about 2 to 3 weeks to recover. So that was typically what we did for many relapsed lymphoma patients until CAR T came along. Now we're actually using CAR T in place of stem cell transplant. So there's been at least a couple of randomized clinical trials comparing bone marrow transplant to CAR T and showing that CAR T is as effective, perhaps more effective. In addition, there have been some cost-effectiveness analyses being done. Actually, one of those was done by our very own Scott Huntington here at Yale, looking at the total costs for the one-time treatment with CAR T versus all of the different steps that we have to do a stem cell transplant. So I think this is an evolving area, and many of us are now moving that CAR T therapy further and further toward frontline therapy.
And would you ever do a transplant after CAR T?
Oftentimes it is necessary, unfortunately, because none of our treatments cure everybody. And so we do have a situation now where patients who relapse after CAR T can move on to stem cell transplant. But the other thing I want to bring up is yet another emerging immunotherapy called a bispecific antibody. This is another way of harnessing your T cells and bringing them to the site of the tumor. In this case, there's actually an antibody that looks like a V. So if you can envision one part of the V is, say, like the CD20 antibody that will take it to a B cell. The other part of that V is CD3, which binds to T cells. So what that V constructed bispecific antibody does is it grabs a T cell and then it ferrets it along to a CD20 positive B cell. Those are also highly effective, and they've been effective in patients who have failed the CAR T. So as you can see, there are many treatments out there now, and we're coming to the point where it's somewhat difficult to know which one of those should be given first.
And with that bispecific antibody, is there something that forces that T cell to interact with the tumor cell?
The only thing that really forces that issue is bringing that T cell into direct proximity with the tumor cell.
So it's physical distance even.
It's also the CD3, when the antibody binds to that T cell, there's a little bit of T cell activation that's going on, stimulating some things to happen in the T cell that we hope then activates it and tells it that it's time to kill the B cell.
So in our last 5 or so minutes, maybe we can talk about T cell lymphoma, which is, of course, what your friend from growing up's father had. And tell us a little bit about the way these patients come to medical attention, because it is a rather unusual rash that you often see.
So this is a disease that manifests itself initially on the skin. And many patients have different kinds of skin findings. Some of these patients were called dermatitis, some of them were called eczema, some of them were called psoriasis. Many of them had the disease for a long time and circled through multiple doctors and had various kinds of ointments put on the skin before it became clear that a biopsy was needed. And when the biopsy was obtained, it showed cutaneous T-cell lymphoma. So that's a very typical story. Now, the good news is that for many patients with this disease, we can treat this disease with fairly conservative modalities, such as the topical creams, topical radiation, and various kinds of oral therapies. But the problem is that, unfortunately, this is a disease that people live with. So unlike other, say, B-cell lymphoma, where you get it, you get chemo, you're cured, perhaps, many of our patients with CTCL have to have this disease and have to manage it for a very long time.
And if I remember correctly, and it's been years since I've taken care of anyone with a cutaneous lymphoma, these can often be pretty symptomatic, and people can have not only what they would perceive to be an unpleasant rash, but it can be pretty itchy too, can it not?
Correct. This is a condition where people can have intractable itching. They can also have flaking and scaling. They can have frequent infections because their skin's broken down. And also, this disease can involve lymph nodes and also can get into your blood as well in more advanced stages.
And when you have lymphoma that is involving T cells, does that also lead to problems with infection because your T cells aren't working properly?
That's a very interesting question and hits head on into some of the most recent research that's been done in this type of lymphoma. So we know that these particular T cells by themselves are flawed and they're not functioning to help and get rid of infections. But in addition, we also know that somehow they suppress their neighboring normal T cells. And so somehow these patients are more susceptible to all types of infections.
Wow. Okay. So what's on the horizon for patients who have these cutaneous T cell lymphomas, and how much progress have you been able to make?
So I think we've made tremendous progress in the last 10 or 15 years in this area. There are a couple of drugs approved, but I'm particularly excited about the most recent approval of a drug called Lymphoma. And the reason is that this drug was actually one of the very first targeted therapies for lymphoma that was developed. It was actually developed back in the 1990s. And what it is, it's the diphtheria toxin hooked up to the interleukin-2 receptor to create a recombinant protein. And that recombinant protein drug targets the IL-2 receptor, which is expressed on T cells. So all of our normal T cells and T cell lymphomas can express this receptor. So this new drug was developed, and it was highly effective early on. Then it was actually taken off the market for a period of time because the FDA required some changes in the manufacturing of the drug. Then it was put back on the market and subsequently has led to the most recent FDA approval of the newer version, which is called Lymphoma.
And it's really quite effective.
It's very effective for patients in that we've actually had patients who've been cured with this.
Wow.
It's able to cure and clear up very extensive skin disease.
Well, that's certainly impressive. And when I hear you talk about the way the drug was developed, it just reminds me of the fact that our techniques in terms of drug development have just come so far. And the ability to engineer these drugs is really an incredibly complicated process.
It is, and it's really amazing to see what the scientists are developing. In fact, one of the projects that I'm working on with our pharmacology department is designing a similar type of a molecule that would target a receptor on T cells that nobody's targeted that may be very effective as we move forward for a rare type of aggressive T cell lymphoma.
Dr. Francien Foss is a professor of medicine and hematology and of dermatology, and is the director of the multidisciplinary T-cell lymphoma program at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.